Today we are going to take a look at the superior surface of the skull. We will see the included craniometric points and the cortical regions related to them. So let's start without any further delay. This is the superior surface and these are its important landmarks. Here we see 2 points and 2 sutures. The 2 sutures are the coronal and sagittal sutures. The 2 points are the bregma, labeled in black circle, and the urion, labeled in dotted circle. I made it dotted because the urion is not an accurately defined point. It is roughly considered the most lateral point of the parietal bone, or in other words, it is the top of the parietal eminence. But now we will start by the bregma. Bregma means the top of the head. It is the meeting point between the coronal and sagittal sutures. In normal adults and along the mid-sagittal surface, the bregma is 12 to 14 centimeters posterior to the nasion. This measurement is sometimes beneficial because in some cases it is difficult to palpate the bregma during planning of surgery without neuronavigation. By the way, this is the same distance between the bregma and the lambda, and we will see that when we talk about the lambda, but now we need to know some information about bregma. The identification and localization of any point on the superior surface depends on the localization of the bregma at first. It is also the cranial landmark of the foramina of Monro. I mean, it is perpendicular to them. If a perpendicular line was traced inferiorly in the projection of the bregma, it will cross between the foramina of Monro. So that if you need to penetrate the frontal horn of the lateral ventricle, you need to identify the bregma at first. You can expect this point of entry by yourself from this axial MRI film. Roughly, the entry point needs to be in front and lateral to the bregma by few centimeters, and this is what was described accurately by Kocher to be about 3 centimeters lateral to the midline and 2.5 centimeters anterior to the coronal suture. Why lateral? Because when the frontal horn enlarges, it goes more laterally. Why anterior to the coronal suture? By about 2.5 centimeters. To avoid the anterior or the lower part of the motor area. If you remember in the previous video, we said that the motor cortex can go more anterior to be very close to the coronal suture. This 3D model shows the Kocher point and its relation to the bregma, to the coronal suture, and to the sagittal suture. Now we are going to see the urion. As I said before, it is not an accurately defined point, but we can consider it the top of the parietal eminence, just above the continuity of the superior temporal line. In most cases, it represents the projection of the supramarginal gyrus. What is the function of this gyrus? This gyrus is a part of the parietal lobe, so it is sensory. It is involved in perception. But what kind of perception? It is the phonological processing of the spoken and written words. Look at this diagram. The primary auditory area is here in the superior temporal gyrus. So it is logic that the area of processing needs to be close to it, and this area is the supramarginal gyrus, which is located superior immediately to the superior temporal gyrus. We have seen the bregma and the urion, and there is a point in the midway between them. It is the projection of the hand knob, a characteristic region in the motor area that is shaped like the knob of the door or the omega sign and is responsible for controlling of the hand. Here in this image, it is colored in red on the right side. To easily remember its rough localization, remember 4x4. I mean it is 4 cm lateral to the midline, 4 cm posterior to the bregma or to the coronal suture. The posterior end of the motor area is 5 cm posterior to the bregma, and because the motor area takes the shape of an obliquely flying bird, it is logic that the hand knob is 4 cm posterior to the bregma. This knob contains the primary motor neurons of the hand with somatotopic organization, where the fifth finger is most medial and the thumb is most lateral. Hand knob defines the motor area in imaging, as we will see in the video of radiological identification of the cortical regions. Now let's take a look at the posterior surface of the skull. Here we see 3 points: lambda, inion, and obesion. Lambda is the site of the junction between the posterior end of the sagittal suture and lambdoid suture. As I said before, it is 12 to 14 centimeters posterior to the bregma. It is not a reliable landmark, so that let's transfer to the second point, which is the inion. It is the most prominent part of the occipital bone. It is usually located 7 centimeters below the origin of the lambdoid suture. It serves as a demarcation line between the supratentorial and infratentorial approaches. It normally overlies the torcula, but there is a considerable variability between cases, so it is only to be used in combination with the information from the CT or MRI. Here we see the obesion, the midpoint of the posterior rim of the foramen magnum. This point is useful during midline posterior fossa approaches and for approaches to the craniocervical junction, which necessitates opening of the foramen magnum, as in Arnold-Chiari malformation. Also, this point is a part of many diagnostic radiologic lines, such as McRae and Chamberlain lines in basilar invagination, or in Bowers ratio in atlanto-occipital dislocation, as we will see later in videos.